welcome everyone. Good evening. My name is Craig Lammert. I'm the Executive Director for the Autoimmune Hepatitis Association. I'm also a hepatologist at Indiana University. We want to welcome you to the first Autoimmune Hepatitis Association webinar series entitled Frontline Report, Autoimmune Liver Diseases and the Pandemic. Before we start, I'm going to allow myself hopefully to share my screen with you. And I ask you all please to be patient too in use of this new technology. So we are so lucky to be partnering with the Center for Autoimmune Liver Disease at Cincinnati Children's Hospital and other presenting physicians to bring you this online series. First, the AIHA was created nearly 5 years ago by myself alongside other patient leaders, where we had aimed to provide support and hope to patients and families affected by autoimmune hepatitis through disease education and provision of research opportunities. We realized there is no time more important than now to provide support to our members, as this world now exists under a new threat called the SARS-CoV-2 virus, also known as the novel coronavirus that causes the clinical disease called COVID-19. The AIHA realizes this time is one of uncertainty for many people. There is a true international need to keep both medical professionals and patients well informed. However, prior models to accomplish this seem a little antiquated, if you will. These methods of data collection, analysis, interpretation, and utilization may not be suited now in the era of COVID-19. We all may find ourselves working in a very new approach where data comes fast and doctors seek to implement this quickly. This is a major reason we've sought to host this webinar this evening. But first, a disclaimer. This webinar series does not replace your primary physician, your gastroenterologist, or even your hepatologist. The AIHA cannot diagnose, treat, or even manage symptoms associated with AIH. Now I want to introduce Erin Anderson. She will be co-moderating with me for this webinar this evening. She is also the Director of Programs and Advancement for the AIHA. Prior to that, Erin served on the AIHA board for 2 years. She's been a tremendous asset to this organization and successful in launching a number of initiatives, including this program. So Erin, we're going to turn it over to you.
Thank you, and thank you all for being here today to learn more about COVID-19. Unfortunately, I think we're all realizing how much more challenging it is to navigate a rare disease during a pandemic. And it's just so great that we can come together as a community and learn more through this webinar series. Our plan is to hold a webinar every other week during this crisis. Our goals are to provide you with the most recent information about COVID-19 and any updated treatment guidelines or considerations for patients with autoimmune liver diseases. We really just want to empower you with information so you can continue to ask questions of your doctor and be your own advocates. We're so grateful to the team at Cincinnati Children's Center for Autoimmune Liver Disease and the Browner family for partnering with us on this effort. This evening, we have 3 presenters who will each speak for about 10 to 15 minutes. At the end, they'll answer some questions that our members submitted to us by email before the webinar. If you have any difficulty hearing the audio, feel free to disconnect and call in using the number and meeting ID that we provided on our most recent Facebook post. Thank you all for being here again. We hope you and your families stay healthy and safe. And we hope we can continue as an organization to be a resource for you. Please make sure you're a member of the AIHA if you haven't already joined. It's free. Just sign up at our website at www.aihep.org and make sure you're following the Center for Autoimmune Liver Disease and the Autoimmune Hepatitis Association on Facebook. Thank you again, and now I'll turn it over to Dr. Lammert to introduce our speakers.
Great, thank you, Erin. And for our first speaker, let's just get into it. Dr. Aaron Ermel is an assistant professor of medicine at Indiana University School of Medicine. He is also a specialist in infectious diseases, and we're so grateful for him to give up his time particularly in time like this, to provide us some insight from the infectious disease doctors. Dr. Ermel?
I'm trying to share my screen here. May not work.
That's okay. I'm going to bring it up for you, if that's
Cool.
okay.
Yeah, it's fine. Thank you.
Maybe.
Right.
Okay, and just identify when you need me to move along.
Sure. Okay, well, thank you for having me. I'm going to present a pretty kind of high-level overview of SARS-CoV-2, what we kind of know now, and then a little bit of kind of some hope in the future of how we're going to be able to handle this disease and try and make it relevant to people with liver disease. Next slide. So just looking at the virus itself, so you're going to hear two names, SARS-CoV-2 and also COVID-19. COVID-19 was coined by the World Health Organization in mid-February. I think this was actually partly just to help improve communication internationally. SARS-CoV-2 was coined actually early on because of its relationship to and relatedness to SARS back from 2003. And so now this is kind of similarly related, but kind of a new version thereof. And when we look at coronaviruses, they belong to like a larger family that we call these coronaviruses because of their shape and the spikes on the outside of their capsid that give it this kind of crown, which is where coronavirus name is derived. And we know that there's 7 members of what is a large family of viruses that cause human disease, but almost all of them except for the 2 or 3 of recent times cause very, very mild disease. And this family actually includes SARS-CoV-2, the newest member to be identified. And when we look at the timeline of the disease, many of us know that it originated in China. It's probably thought that early December was the first case. There's some case reports when they track this back that this might have started as far back as the 8th of December, but it wasn't until the end of that month that actually China was able to recognize this pattern of clustered unusual pneumonias. And then it was by the end of January where they decided to place what we call a cordon sanitaire, or a border around Wuhan to try and limit all travel. And then they placed all individuals within that population under quarantine, a very strict quarantine actually. Next slide. And so then in January 2020, this is where we had some movement as far as our understanding of the virus, where in China, they were actually able to identify the isolate and then sequence all of its genome. And this is a pretty sizable genome for virus, so it was a pretty big accomplishment because I think this is where we were able to start developing testing and to look at therapeutics. So then the first test kits were actually developed in China and then subsequently in Germany with other collaborators within the European Union. And right at the end of January is when we started to see the first cases in the US, and many of you have known this simply because of the press that was devoted to the outbreak in some long-term care facilities in Washington State. From there, we saw it spread globally, and then it was officially labeled a pandemic by the World Health Organization in February. And then as of today, we now have a pandemic where that has already caused 638,000 cases and led to a little over 30,000 deaths. In the US, we have now broken the 100,000 case mark, and we're headed towards 2,000 deaths. You know, by the time that I have looked this up online and then mentioned it during this talk, we've probably already added to those numbers. Next slide. And when we look at what common symptoms and who's affected, men and women seem to be affected relatively equally as we look at every country, despite differences in other appearances of the disease. We're seeing that it's split about 50-50 between the genders. The symptoms, unfortunately, are actually pretty common this time of year, where we see fever, cough that's usually dry, followed by shortness of breath. And then what's most recently been described as gastrointestinal symptoms. So this can be nausea, vomiting, or diarrhea. Early reports of this disease did not include such gastrointestinal symptoms, but it's common enough that we're actually now starting to add it to our screening procedures. And it actually appears to be very similar to influenza. If you look at the presentation, however, it takes a little bit longer to develop relative to the time of exposure. And that's been a bit of a problem in trying to control the disease, because most symptoms will appear within 2 to 14 days. We'll see a median of 5.1. There are reports that exposure to development of disease or incubation period may be as long as 3 weeks. So when you think about trying to control the disease, it makes it very challenging in that people can walk around asymptomatic for some time before they actually are presenting for care, which is when they're being identified. Which then, when you look at transmission as a part of control, we think of transmission as basically by droplets. There was some concern that this disease early on was actually airborne, which makes it much more contagious, if you will. But we've kind of worked through this to think that this is mostly a droplet spread, and that the range is about 3 to 6 feet. And next slide. And so when you're worried about droplets, you worry about droplets getting on surfaces, and this is a very common question that comes to me from a lot of my patients, which is, well, if I touch various surfaces, what is my risk? So there was actually a group of scientists who published in the New England Journal of Medicine last month, trying to look at various common surfaces and how they affect virus and virus survivability. So there's 2 ways you can look at this: is can we merely detect it on a surface, and if we detect it, can it actually cause infection? So they tried to do that. When you look at aerosols, so the most common method of transmission, they actually set up their own little chamber and tried to turn this into little droplets and then look to see how infectious and how much virus they could measure over time. We know that after a period of a few hours, you can still identify infectious virus. And so the mean time is about 3 hours where we have significant infectious titer. But this reduces over time. So when you're in hospitals or you're in areas, you'll see that if we have a patient who's had COVID, we remove them from the room and they're not going to be going back to that room. We give at least 3 hours before any other patients or anyone else goes in there, even after cleaning. Other common surfaces would be stainless steel and plastic. And this, when we looked at how viable or how infectious a virus could be, that is where you're hearing some of these news reports of up to 3 days. However, if you look at how much virus is actually there, it's very, very little. So it continued to die over time. But this is kind of relevant and kind of helps us to emphasize what surfaces need to be cleaned more often than others. Cardboard, interestingly, had almost no viability after a day, and actually copper, there was very little viability after 4 hours. So there may be something there about how we prioritize what types of surfaces are available in hospitals and where we go from here as far as control and spread of infection. Next slide. So when we look at risk factors, so there's no established risk factors for infection or transmission. Okay, so this is apart from developing severe infection. When people ask, what's my risk of getting it? I can't tell you just based on you. What I can tell you is based on certain characteristics, we look at how severe infection could be in your case. So when we look at severe infection, what's coming across consistently is that individuals who are older than 60 years, not uniformly so, we do see younger patients who develop severe disease. But when you look at large data sets, it still looks like 60 years is about the cutoff. We have recent reports of younger individuals developing severe disease, but like I said, the majority of them are greater than 60 years old. And when we look at case fatality rates, who actually is dying from this disease, it actually remains relatively low in younger individuals when we look at these larger data sets. So Italy right now still experiencing a pretty severe infection rate. But if you, despite that, and despite a higher case fatality rate, if you actually look at subsets of patients in the 2,000 to 3,000 range, it's still relatively rare that young people get severe disease. In things that will also predict severe disease and things that patients have, which you wouldn't always associate with developing severe disease related to an infection, have been looked at across many of the populations. And what seems to stand out is chronic kidney disease, pre-existing cardiovascular disease, including heart failure, high blood pressure, diabetes, and then possibly obesity, though this is not always consistent. What we don't know is actually, when we look at these, is that uncontrolled high blood pressure, uncontrolled diabetes, uncontrolled cardiovascular disease, other factors. So we won't know this for a few more months, but these are the things that we've noticed consistently across various populations. When you look at these case reports and you look at the population, you know, there's certain special populations that we always worry about, and these are those who are taking immunosuppressants. Do they have rheumatologic disease? Do they have chronic liver disease? And they make up such a small portion of these populations that we can't tell yet if they really have risk of having severe disease. We think they will, and we treat them as if they will. But again, these numbers are very small, and it's a little early to develop the true risk. Next slide. So how do we reduce transmission? I think a lot of people ask me this. These are questions I get messaged to me daily. There are just a few commonly applied methods. You've already experienced a lot of these that are happening in our country and in others. There's an overall theme of essentially reducing the likelihood that one would come in contact with an infected individual, right? So this is reducing daily interactions with others whom you do not know are actually infected. So the first one that's become very popular, social distancing. So just reducing that contact, not going out to these areas like bars, restaurants, concerts, and gyms, not congregating in larger groups. We don't really know what constitutes a larger group. We have areas in Africa, so I work a little in Kenya. They're instituting anyone group larger than 2 people can't congregate on the street. And we have other places that are suggesting 10 as our cutoff. So we don't know that magic number, but just reducing the number of people around you should help. And then there's the restriction of travel, which was taken on very early. You can see how quickly this spread, likely due to how global we are and how mobile we are as a people. But any type of travel, moving you from one place to another, whether it's by air, car, or train, can place you at risk of either contracting or taking the disease with you. Now, there's other more drastic measures that were performed in China as part of their quarantine, which was full isolation and quarantine of positive patients and also healthcare workers. They actually had a tiered system and a priority system where they moved these types of patients into a very strict quarantine, actually cohorting or putting all of them together in the same place in hotels or in areas that were turned into makeshift hospitals, and really trying to isolate that population from those who had either not been exposed or those who are not yet infected. And then what we are seeing now, partly due to a lack of testing kits, but also as a strategy to identify those who are most likely to be positive, are priority stage testing schemes, which is actually what the CDC has been recommending recently, where we have a 3-tiered system moving through those who are most likely to be infected, those who have been exposed but may not be infected, and then those who are least likely to be infected. So we're looking at tiers 1 and 2 as our target populations for testing right now. Next slide. So what do we do with immunosuppression? I'm not going to spend too much time on this simply because I have 2 wonderful experts who will be speaking after me regarding this, but we don't know that much from the current pandemic. This has been relevant in my practice because I treat a lot of patients with HIV, and this is the first question that they ask. We have looked at this in other outbreaks, and we know that the people with, who are immunosuppressed do not fare as well as those in these prior outbreaks. But again, at this point, we don't really have a lot of data to be able to tell us. Chronic liver disease is also considered a risk factor, but it's borne out in some of these populations, but not in others. And as I mentioned before, the data is still not quite that good yet because we haven't hit, I think, enough populations or I had enough time to look at the information that we have. Next slide. Just kind of hope for the future. We do have one ongoing NIH-sponsored clinical trial for vaccine that was announced a couple of weeks ago. It's kind of an interesting vaccine. It works by presenting pieces of the virus genetic material to the host or the person so that they produce the protein and actually produce their own response. This is a kind of a novel way of developing vaccines and may be particularly useful in this type of infection. And hopefully that type of immunity will be durable. Only healthy individuals are being enrolled, so we're really, this is very early on, so We want kind of the healthiest individuals who have the best responses initially so that we can demonstrate that this even possibly works and then move on to everyone else. But this isn't the only vaccine. So there's probably 8 or 9 vaccine candidates from various producers of vaccines, various private companies, and partially from government-sponsored funding that will begin clinical trials, I'm sure, here shortly. I did receive a few questions regarding certain specific things to this group.
And Dr. Ermel, we're going to save questions for the end if you can hang out.
Oh, sure. Okay. Yes.
If that would be okay.
Yeah, that's
Thank
totally.
you. Thank you so much, Dr. Ermel, again, for going through that piece in regards to the ID perspective. But as you said, we do have a few other experts with liver knowledge, but also based on immunosuppression that we'd like to get to as well. So thank you. Our next speaker is Dr. Alexander Mivka. Dr. Mivka is a hepatologist, but also a translational researcher at University of Cincinnati's Children's Hospital. He's also there as the director for the transplant program. So join me virtually in welcoming Dr. Mivka, which will be sharing his slides for him.
Greg and Aaron, thank you very much for inviting me to give a little overview on the things we know and we don't know about autoimmune liver disease in an era of a new and severe respiratory virus disease, COVID-19. So it's my distinct pleasure to serve here as the resource, especially for our pediatric patients with autoimmune liver disease, but I hope I can also do justice to patients who have outgrown the pediatric and young adolescent age group. So next slide, please. So let's go right to the key of this first webinar. Are patients with autoimmune liver disease at increased risk for contracting COVID-19 or for experiencing more severe disease? And as Craig did in the beginning, I think it's very important to put another disclaimer here. We really base all that on very limited data and on a preliminary assessment of the data we have. So the recommendations may need to be revised perhaps soon. And that's why I applaud Aaron and Greg to actually not have a one-time webinar, but to offer a webinar series to address various aspects, but also to help us updating the information we share here with you. As it was pointed out before, our recommendations are based on various aspects. To some extent, they are based on what we have learned about autoimmune liver disease during previous virus epidemics, the SARS in 2003, the MERS in 2018, and then the H1N1 influenza. Some of it is common sense, and we will talk about those things as well. And then to some degree, what the epidemiology has told us from the outbreaks in Wuhan, China, and where Italy is, who are unfortunately ahead of us in their curve. There is an absolutely urgent need for data from the United States. There is currently a registry in place which collects data from patients with liver cirrhosis and COVID-19. That one does not particularly address the question of immunosuppression and whether immunosuppression and autoimmune liver disease or other autoimmune disorders like rheumatoid arthritis predispose our patients, and what treatment regimens may be chosen at various centers, and perhaps whether there's a hint towards a better outcome with certain protocols. So we are working now on developing a registry for autoimmune liver disease and COVID-19, and we will get back with the community to get your input on that. Next slide, please. It was also mentioned before that no matter what the epidemiology may show us, I think it's probably the safest to start from a perspective of overabundant caution and say autoimmune liver disease is a high-risk condition for COVID-19. And there's some, at least theoretical evidence which would suggest that. We know that in those previous epidemics, especially in the H1N1, patients with systemic lupus and rheumatoid arthritis did experience more severe disease. We know that any type of chronic disease and chronic liver disease reduces the barrier function to control infections, typically for bacteria, but there's some evidence that it may also apply to viral conditions. There is, and we will hear more about that from the next speaker, SARS-CoV-2 induces a particular liver injury, which at least in theory may lead to a decompensation of a chronic liver disease in some patients with autoimmune liver disease, although that has absolutely not been described, but from a theoretical consideration and from a cautious perspective, that is a possibility. And then, of course, we must not forget that patients with autoimmune liver disease have a chronic disease. They are exposed to potentially patient or staff members who carry the disease and could potentially spread it because of their visits to the hospital, because of the studies in the hospital, and because of their blood draws at the hospital. And that concern is an important driver for a lot of the policies we will share with you and which you probably have already experienced. And then, of course, the other side is the medications. We prescribe our patients with autoimmune hepatitis medications to protect from these autoreactive T lymphocytes, and we suppress the T cells in their activity, so that in theory, of course, may impair the body's ability to fight the virus and impair the antiviral immunity. So next slide, please. But has those theoretical concerns borne out epidemiologically? And that's a good news, and I think that's something I want to emphasize going forward. From what we have learned from China and from Italy, despite these theoretical concerns, there does not seem to be evidence that patients with autoimmune hepatitis or PSC or overlap syndrome belong to the high risk group. And it was already mentioned before, and I share here some original data with you where a lot of these recommendations come from. These are is a data table from the New England Journal of Medicine, which reports the coexisting diseases in 1,000 patients with COVID-19. And you can see that 80% of those patients had a milder disease course, and then 173, about 20%, had a more severe disease course, which required admission to the intensive care unit, ventilation, and unfortunately was associated with death in about 3.5% of the patients. And by comparing those columns between non-severe and severe, you can see which conditions may predispose to a more severe disease course. And you can see that I listed that in the order of importance, that the conditions which are particularly associated with a severe disease are hypertension, diabetes, COPD. And then when you look at cancer, which was considered a predisposing condition, that is much less so associated with severe disease. Immunodeficiency was only described in 2 patients out of 1,000 patients. So it's a very, very small percentage in which immunodeficiency was associated. What I would also like to emphasize here is that only 23%, if you go up to the row, the third row, coexisting disorder percentage, only 23% of all patients were found to have a coexisting disorder. So that may mean that the majority don't have a coexisting disorder, but it may also mean that it was not accurately ascertained at the time of when that study was conducted. These are tumultuous times. So we certainly have to learn more about the disease and what other associated diseases may predispose. Next slide, please. And this was some great news we received last week from our colleague, Dr. Antiga, at the Papa Giovanni 23rd Hospital in Bergamo. He is a pediatric hepatologist who cares there for a large group of patients who received a liver transplant in childhood age, and also 100 patients with autoimmune liver disease. And out of those 800 patients potentially at risk for COVID-19, none of them was found to have COVID-19. So his assessment of wrestling for 6 weeks with this serious disease was that autoimmune liver disease or transplant did not predispose his patients. Importantly, that is about children. Children seem to have a milder course anyway, but I think that is overall reassuring news. We have an American Association for Study of Liver Disease blog and a special interest group. The patients reported there are very few. There was one 49-year-old patient with autoimmune hepatitis, but other risk factors who developed mild disease. I talked with our colleague, Dr. Vittorio, in New York City, who is doing a remarkable job under incredibly difficult conditions there. And I hope at a later time, at a later webinar, maybe she can share with us her experience directly. But so far over there, none of the patients she is aware of has autoimmune hepatitis or PSC, but they did diagnose COVID-19 in a 6-month-old infant after liver transplant. So again, we urgently need more prospective data from the United States and Canada to understand whether the observations in Italy and China hold true for the United States, but currently there's no evidence for significantly increased risk for COVID-19 and autoimmune hepatitis or PSC. Next slide, please. I will go through this here briefly because I know the next speaker will spend some more time of it, but it is important to realize since we are dealing with a chronic liver disease that the SARS-CoV-2 enters the cells by binding through the angiotensin converting enzyme 2 receptor, which is used as the docking elements to get into the cells. And these ACE2 proteins are expressed on bile duct epithelial cells. So there is, at least in theory, a possibility that the virus has a direct effect on the liver, especially on the biliary tract. Elevated liver enzymes are commonly found, and up to 35%, especially in patients with severe disease. Sometimes it can be difficult to see whether those elevated liver enzymes truly come from the liver, or they may come from muscle or other organs. A low albumin level was identified as a predictor of more severe disease, and histologically, steatosis, fatty liver, and some mild portal inflammation was found in these patients. Certainly no biliary injury from what we have seen so far. What would be important is that if any of our patients who are hearing now that webinar, get diagnosed with COVID-19 and LFTs may be obtained at that time, those elevated LFTs may not have anything to do with a flare in the autoimmune liver disease. So it's very, we should probably be very careful in assessing LFTs and interpreting those in patients with underlying chronic liver disease. Next slide, please. This is a slide I included for our patients, particularly with PSC, who may have associated IBD, and of course to ask for understanding of why we try to reduce procedures as much as possible. It was mentioned before that GI symptoms are sometimes one of the only and predominant symptoms in patients with COVID-19, and up to 16% patients had only diarrhea without any cough. The virus, at least the RNA, can be detected in a large number of patients in the stool samples, and it can be present there for 30 days after. It's still unclear whether they they can form a full virus or whether it's just a detection of the nucleotide acid. But that is important, and that is why we are so careful nowadays with endoscopies, performing endoscopies, because of the concern for spreading the virus, especially with a colonoscopy. The IBD groups are developing registries. They have already collected information about 72 patients as of March 21st, and 5 children with IBD and COVID-19. And so far, at least among the children, all had only mild disease. There was no predisposition for more severe disease. Our IBD colleagues came to the conclusion as of now to recommend to continue the IBD therapy without any change in medication as if possible. Next slide, please. Here I would like you to focus first on the center of the slide. That's a cartoon I borrowed from a very recent article on the pathogenesis of COVID-19 disease. And you can see on the left part of this a unit of the lung, the alveolar, you can see that the virus enters the lung, and then it infects the type 2 alveolar cells and elicits an immune response of the body to try to clear the virus, which includes T cells. That is not particularly effective. That's why only very few patients are prevented from advancing in their disease. But that is important to understand. During that early stage, elimination of the virus relies on the cells in the lung directly, the alveolar cells, as well as macrophages and T cells. And then when the virus has replicated enough and infected more tissue, then there is an aberrant immune response by many inflammatory cells, leading to a cytokine release syndrome, and that is what causes the damage. So if we now look at our medications we prescribe to our patients with autoimmune hepatitis and PSC, they may have various effects on these 2 stages of the disease. If we go on the left, medications which we typically prescribe, corticosteroids, antimetabolites, Imuran, Celcept, Prograf, and increasingly JAK2 inhibitors, Gelgent, they may indeed impair the ability of these T cells to control the virus replication that could, at least in theory, lead to an increased susceptibility, even though that has not been shown so far in our patients. But it certainly could explain why there is a concern that patients who are on these medications shed more virus and for a longer period of time. So it's very important that if our children on these medications are diagnosed with COVID-19, they could certainly be a risk for other risk groups to contract the virus from them, because they may shed the virus for more than 14 days or even 21 days. And now on the other side, on the right side, the severe stage, that's how our medications may affect the progression of the disease during the cytokine release syndrome. And during that phase, actually, some of the medication we use in our patients may actually have a beneficial effect, because they suppress those cytokines which promote the tissue damage, the lung damage, in particular the infliximab or anakinra. The role of the corticosteroids is uncertain, and that's why most people would recommend to use as low doses as possible of corticosteroids, but not to go below a dose in which we can develop adrenal failure. Next slide, and that should be my last slide.
Great. Thank you, Dr. Mitka. A lot of important information and maybe some positive findings as well. And I'm assuming time will tell further. Let's keep things moving. We'll go to our third and final speaker. Dr. Marwan Gabriel is a colleague of mine at the Indiana University School of Medicine. Dr. Gabriel, besides being a great colleague and close friend, is an expert in liver transplantation, but also in immunosuppression thereof as well. So join me virtually in welcoming Dr. Gabriel. I will be sharing his slides with you momentarily.
So while Craig is setting this up, I'll share with the group. I only have a handful of slides. It's really going to be reinforcing what has already been presented so beautifully by the other presenters. It's a pleasure to be with you all. The themes here for these overall approaches: what do we see in terms of liver injury with COVID-19? What if you have underlying liver disease? How do we approach immunosuppression if we are dealing with COVID-19? So first couple of slides really just kind of describe what we know about liver injury with COVID-19. It's been stated before, but really we can't say it enough. This is all preliminary database, so we don't really have enough information to make very strong statements. But this is what we know. The bulk of the data really are coming from China, but I think they've done a good job describing clinical features and outcomes, and it's been helpful. Now, we do see a fair amount of liver injury, and by that I mean seeing abnormal liver enzymes, which Dr. Methka has suggested previously that this may not actually be coming from the liver even. It could be muscle injury, because ALT and AST that we all follow with a variety of liver conditions also come from skeletal muscle. But abnormal liver tests, I would say, are quite common with COVID-19 and SARS infections, unfortunately. There is a fairly comprehensive number of patients, I think over 1,600 reported in some of the variety of publications. Some of these have been collated in subsequent recent publications and are very helpful. We do know that there is an underlying liver disease in a small but significant subset of patients. It really only amounts to about 42 patients from these variety of studies. So not as much as we'd like to know definitively what's going on. That in itself is encouraging, perhaps. The liver injury certainly seems to be more prevalent in the more severe cases. So you're more likely to see higher abnormal liver enzymes in patients that have severe COVID-19 versus those that don't, although you can see it in both cases. So it's not dependent strictly on having a severe respiratory illness and febrile illness with the condition. What we don't really know is how do the underlying liver conditions actually influence outcomes in COVID-19. It certainly looks more promising than not, but the jury's still out, and again, this moniker of just preliminary data. The mechanism of liver injury was beautifully described in the earlier slides. I won't spend too much time other than to say that we don't, our understanding is that most cases of liver injury are likely related to this dysregulation in immunity, the cytokine storm, and immune-mediated injury to hepatocytes. And this is something that has been seen in previous SARS-type infections. And it seems to correlate with the severity of respiratory illness and other features of the cytokine storm. So it tends not to be an isolated liver injury by itself in the absence of these other immunologic features of severe inflammation and cytokine storm. And it also doesn't match up with evidence of hepatic viral replication, at least with prior types of viral conditions, SARS included, the prior SARS in the early 2000s, and then MERS in 2018 in Saudi Arabia. You've heard the muscle injury, so these enzymes, ALT and AST, could be coming from other sources. Some experts and publications have mentioned drug toxicity. It's always, has to be considered as one of these things that you can't exclude, and you have to think about it. However, usually our understanding of risk of drug injury, particularly idiosyncratic drug injury, an injury from a medication that isn't typically associated with drug injury, and it's just an unusual idiosyncratic immune reaction to that medicine. Those types of injuries are rare, 1 in 100,000 cases on average. So to give you some idea, we're not thinking that the bulk of cases of liver injury and abnormal liver tests will be related to drug toxicity, but we always have to consider these possibilities. And of course, you've heard that the virus has some predilection for epithelial cells and bile duct cells, and certainly can be a direct hepatic injury from this. Keep in mind, patients with severe infection can have overall severe illness. Associated with that is shock, low perfusion pressure, and the liver, if it's not getting enough blood supply and oxygen, can get hypoxic injury as well. So there's a variety of types of injury that one can see and processes that can cause abnormal liver tests, although it doesn't look like the bulk of these are related to actual hepatitis per se. Craig, if you give me the next slide. Thank you. This next slide really just summarizes some of this data. I'll just highlight that on average, patients with abnormal liver function are probably higher than the 15%. It's probably somewhere in the 20 to 50%. And certainly almost twice as likely to see abnormal liver function tests in patients that have severe infections, fevers, respiratory insufficiency, etc. So it's just a summary slide, but just sort of highlighting these features. Outside of that, I think the numbers are just too small for some of the anecdotal comments made, but we'll move on to the next one. In terms of chronic liver disease and the risk of worse outcomes, so if we have someone who has underlying liver disease, what are we concerned for with outcomes with COVID-19, and what do we know? So in terms of the concerns, one, the respiratory illness and the acute respiratory distress syndrome, ARDS, is certainly something that we worry about in patients with advanced liver disease. There's been one study looking at patients with cirrhosis who developed ARDS, and they certainly had worse outcomes and higher risk of 90-day mortality compared to patients who had ARDS without cirrhosis. But I want to highlight that this is not COVID-19 data. This is specifically studied on patients with advanced liver disease cirrhosis, not those in the absence of advanced fibrotic disease. We also worry, and this has already been discussed with other presenters, the concern for a worse immune function and inherent immunosuppression just by having advanced liver disease. So on this basis, the ASLD, which is the American Association for Study of Liver Disease, drafted a letter to the CDC recommending that patients with chronic liver disease, and of course those with liver transplant listed to be transplanted, also be included on the list of patients with chronic illnesses and immunocompromised states, and hence to be considered vulnerable for COVID-19. And I think that's a fair way to approach things, and for all of us to treat our patients and ask our patients to work on this basis, to consider that they are in fact vulnerable until proven otherwise. Well, what has been reported? Well, we've highlighted that really very few patients overall with underlying liver disease being reported in what we've seen with over 1,000, 1,500 patients with COVID-19. That in itself is somewhat encouraging. Additionally, we've not necessarily seen a higher mortality rate in those with underlying chronic liver disease. So does that mean that we are highly confident? No, of course not. But certainly the numbers reassure that at least so far, preliminarily, we're not looking at increased risks of mortality and worse outcomes with COVID-19. Not to understate the fact that the infection might be more severe. There may be more viral shedding for a longer duration of time in patients with immunosuppression. Great, we'll go to the next slide. And this slide is, has a lot of detail on it, but I'll highlight a few things. Pretty much all of these studies are really reporting what happens in terms of those with severe infections. So you can see it's a relatively small subset compared to the overall number of patients, the denominator of 1,600 patients. Nevertheless, I want to highlight a couple of things. If you look at those with severe infection, the ALT and AST values are presented, and these are your average values. And so for the most part, they're not they're not terribly elevated compared to baseline. Not to say that you can get severe elevations in enzymes and even acute liver injury, which has been reported, and fulminant failure. But for the majority of patients with severe with severe COVID-19, we're really looking at mild, modest elevations in liver tests, at least based on these values. The good news too is that they also are describing clotting time, the prothrombin time, and also the bilirubin. I'm not sure how many of us in North America would look at micromoles of bilirubin, but I'll tell you that on average, this is a mean bilirubin that's not terribly elevated. It's around 1 or maybe even less. So we're not looking at jaundice in these patients with severe COVID-19. We're not looking at coagulation disorders and signs of failure. Those are the things that we look at to give us a sense of, is this liver failing? So those are reassuring things. And when you extract those patients with liver disease, we don't have the line item numbers as far as their liver tests, but only to say that the mortality rates certainly seem to be lower than the overall mortality rates that are described for patients with severe disease. So again, some measure of reassurance perhaps from the data so far. And finally, just a couple of words on what's the guidance for immunosuppression in this pandemic. So this is a summary from the AILD circulated document. They sent this out about a week ago. And the overall recommendations are as follows. At this point, if there is no evidence of COVID-19 infection, we continue with systemic immunosuppression for the time being without any changes or dose reductions in the absence of a flare or rejection or some other reason to be ramping up immunosuppression. So that's going to be the vast majority, we all hope and pray, of course, of our patients. So those without COVID-19, we're not expecting any adjustments. If, however, COVID-19 was, I'm going to say, suspected or confirmed at this point, I imagine that we are going to be able to confirm infection relatively quickly in most cases at this stage with ramping up of testing across the country in medical centers. So again, the comment on prednisone, that's been uniform. That's pretty much how we're approaching it. Try to avoid high dose prednisone if we can help it, but don't reduce so quickly and so low that you end up with adrenal insufficiency. That in itself can be deleterious. If patients are on antimetabolites, things like Imuran, which is azathioprine, or mycophenolate, also known as Myfortic or Shelsup, consider reducing those doses, particularly in patients that are having fever, low white cell count, which we can see with either agent, and certainly if there is worsening clinical condition with pneumonia. With respect to other agents, I don't think that most people with autoimmune hepatitis would be taking calcineurin. Those would be things like cyclosporin and tacrolimus, but I'm sure some are. The recommendation is to consider using if there is again worsening clinical condition, worsening pneumonia, fever, low white cell count, without necessarily stopping these agents. So you can see that there is lots of room here for individualization, and I think it's risk-benefit, and certainly having a liver specialist in your corner if you're a patient who knows you well, knows how your underlying immune disease or immunosuppression has been managed over time, and what you really need to manage things is going to help with Gestalt, I suspect, in finessing managing immunosuppression, God forbid, should anyone be dealing with this infection. That's all I have. I think we could potentially move to the questions and answers.
Yeah. Thank you, Dr. Gabriel. I really appreciate it. And we're going to move into our question and answer period for the next 10 minutes, if that's okay, if our speakers could hang around. We opened up questions to our online portal through email and social media the past weekend, and we've compiled about 12 different questions. We don't have to get to all of them, and some have some similar themes, but ones that distilled really the sentiment of a lot of our patients and family members and what they're concerned with. So myself, along with Aaron Anderson, will walk through some of these questions, at least at this time. I am going to bring another screen up just while we're waiting here for one moment. So, Dr. Ermel, if you're still there, you spoke about this briefly, and again, this is a common question I get as well, and this is kind of a two-parter. But this idea of the immunosuppressor at risk for actually acquiring the coronavirus, and particularly those individuals that have called me the most about this tend to be healthcare workers. Is there a way that you could counsel the immunosuppressed patient and or someone that is on the front lines or has the highest risk of acquiring this viral infection?
Sure. You know, when I meet with my own patients who are somewhat immunosuppressed from other conditions, they're kind of akin to what we're discussing here. And what I tell them is that, when it comes to precautions, you actually should follow the precautions that we tell the rest of the country, which is frequent hand washing, reducing contact with other individuals. But when I talk to them about actually the risk of acquiring the disease, there might be some increased risk of establishing an actual infection after exposure, but actual exposure is going to be the same. So those are factors that we can control for any person, regardless of their immune suppression. And so what I tell them is that it's more important that they do it, not because I'm worried that they're more frequently going to be exposed, but because they're more likely to develop severe disease. And then when I've actually talked to some healthcare workers in our own system about these issues, actually as a division, as a department of medicine here, we actually set up some guidelines as to who we felt could really actually be on the ward seeing this patient. And what we have counseled people is suggesting that these individuals, if we can, who are on immunosuppressants but are healthcare workers, can reduce their exposure by, say, not entering what we call COVID-19 wards, which is where we're putting all the patients who have this disease together in the hospital, that if they can serve other functions in the hospital relevant to patient care and reduce that exposure, it's probably better. Okay, so the one way of just reducing exposure is not having them near those patients. So they often do other functions which they see patients who don't have COVID-related disease, or they help us with a lot of our virtual visits and things like that, where they're able to administer care but not be directly in contact with those patients.
Great, thank you, Dr. Ermel. We'll now go to Dr. Mika. We have another question related to immunosuppression from a member who asks, I get frequent labs from my doctor to manage my immunosuppression, but I am concerned about going to the lab to get my labs drawn. How should we balance the risks and benefits of going to the lab for testing during a pandemic?
This is an excellent question, and I think we all have to develop strategies here together. One of my patients just recently had acute gastroenteritis, got a blood work, gastroenteritis went away, but the phlebotomist was later on tested positive for COVID-19. So now my patient ended up in quarantine. That's exactly what we want to avoid. That's why we try to have as little contact in the hospital, as little presence for tests, for ultrasound, for MRIs, for blood work as possible. On the other side, it is very important that that has been shown in other studies before during influenza epidemics, that patients with chronic disease ended up getting suboptimal care because they were not seen frequently enough. So we have to find the fine balance. Specifically for autoimmune hepatitis, if a patient has a stable regimen, is on low dose prednisone, on a dose of Imuran, hasn't had elevated LFTs, is in remission, for all means space it out. If a patient knows that he or she has not taken regularly the medications before, may have taken not the Imuran as prescribed, and is now trying to optimize the care by taking it as prescribed, we may want to double check on the LFTs, making sure that we don't get into trouble with some dosing. So very important to individualize it with your provider and then see for how much you can space it out. But if it can be spaced out, please space it out.
Great, I think good information. Dr. Gabriel, if we could pick your brain, and particularly in an area that I have a lot of interest in. We have patients that are in remission that haven't been on medications for a while, but they know the risk, or there is a potential risk for liver injury in the setting of COVID-19. How would you counsel a patient in terms of reactivation of AIH? I suspect it's speculation, but we're interested in maybe your thoughts.
Yeah, no, I think it's a very good question, and I fully understand the concern. And this patient is well read, by the way, because this is the fact that I'm saying that I'm hoping will offer some reassurances. The fact that autoimmune hepatitis can be triggered by different liver injuries has been well reported. We've seen it in a variety of acute viral illnesses. Hepatitis A, hepatitis E, hepatitis B. Hep C has fairly significant, maybe a 5% overlap with autoimmune hepatitis. So we know that de novo autoimmune hepatitis generally can be seen with acute viral illnesses. Reactivation, I believe, has been reported with Epstein-Barr virus infections or reactivations as well. But in general, these tend to be fairly rare cases and more in the realm of case reports, so anecdotal rather than high-level concerns. In the transplant world, I'll share with you where we do see fairly frequent viral reactivations, more so than for perhaps de novo bad viral infections, definitively. But again, we've seen perhaps anecdotal rejection in the setting of an acute viral hepatitis, but those are really quite rare. So it's possible, but I would consider it rare. I think the main key, of course, is to keep it in the differential. If someone is dealing with COVID-19 and requiring care, certainly important to make sure they do get liver tests done if there's underlying liver disease like autoimmune hepatitis. And again, keeping their hepatologist who knows them, knows their immune system, disease course, what's going on. The bulk of cases of liver injury are not going to be likely acute hepatic. There's going to be one of these differentials that we've talked about. But I think reactivating autoimmune will be a thought, but not likely a common scenario.
Great, thank you, Dr. Gabriel. We'll go back to you, Dr. Ermel, with a question around personal protective equipment. In the hospital, personal protective equipment consists of a regular face mask. Is this adequate to prevent getting infected with the virus in the acute care setting? And then also, how effective is a regular face mask for healthcare workers or for those who use it when leaving home now that community spread is on the rise?
Right, so this is a pretty good question, and one that seems to change with the day based on the reports that come out. But we know that now at the stage of the pandemic, that a surgical mask, one of the more standard masks that we have available in the hospital, are very effective at preventing COVID-19 infection. This is for people who are in our typical droplet isolation. Typically, when we're in close contact, say an examination stage, we do prefer a surgical mask with a face shield. So we know that this is adequate and effective while for routine care of these patients. Where you'll see people putting on different masks, the N95s that many have heard a lot about, that filter a little bit more finely and provide a slightly different seal. Those are actually really used in what we call aerosolizing procedures, where if somebody has to perform a bronchoscopy or even an endoscopy, anything that places you very close to the patient's mouth, and also causing them to either cough or with washing secretions, anything like that. In the general public, it is thought that wearing surgical masks, only the surgical masks, out in public are actually to be effective now. It was originally thought that maybe they wouldn't be, but with the level of community spread, we think that they may be advantageous in the public, though we're not advocating widespread use just yet simply because of supply issues. But if you had a supply, being able to wear that in public, especially if you have some sort of immunosuppressing condition, would be beneficial.
Great, thank you. Hey, Dr. Meethke, I understand maybe your connection may be a little bit weak, but if we can sneak a question in really quick. As you know, patients with this disease are very insightful, and they've seen the data for hydroxychloroquine or plaquenil, and we know many of our patients have rheumatologic disorders and may be on this drug as well. Any role for prophylaxis?
This is an excellent question. I think obviously it has gotten a lot of publicity, the request to try to test chloroquine or hydroxychloroquine plus azithromycin in patients hospitalized. The basis for it is relatively thin. Chloroquine and hydroxychloroquine, of course, was found to be efficacious against malaria, and then it was later on found to block virus replication, hepatitis B, HSV, various viruses in vitro. And during the SARS epidemic in 2003, it was also tested, and it was found to block the virus replication in cultured cells very well. And it did it in concentration, which are similar to the concentration in the plasma of patients who are treated with dosages against malaria. So there is some evidence, but it's certainly very early evidence. And what we know about COVID-19 is from about 100 patients treated in China with chloroquine and azithromycin. And out of these 100 patients, those treated with that combination had a decreased progression of the disease based on their chest CTs. But to come back to your questions directly, if a patient is already on chloroquine, then certainly stay on it. If there is a possibility that it protects, why not taking that advantage? On the other patients who are not being treated with it, it should only be treated under guidance of physicians, ideally in a clinical trial setup. The combination of azithromycin and chloroquine has some potential to cause arrhythmias. They prolong the QTc time, especially in combination with other medications, patients who get seriously ill. That could be a combination we want to avoid. So if you are on it, stay on it. If you are not on it, don't start it yourself. It is not as innocent as it sounded.
Yeah, I think great information. And before we let you go, because of your connection, can you answer just one more? And because of your expertise, particularly in children, once a vaccine is available, whenever that will be, how would you counsel patients on immunosuppression and your ability to form, the appropriate immune response to have a solid response to a vaccine?
You know, this is a great question, and I think I admit I think this is a challenging question, especially knowing that this new vaccine, which is currently being developed, is based on RNA encoding the viral protein. So depending on what that vaccine actually promotes, whether it's a T cell response, a B cell response, there are many things to consider. For the vast majority of vaccination, and we are probably safe to assume that that new vaccination will be somehow similar to the vaccination we have tried, whether it's influenza or other vaccination in viruses against viruses like influenza in particular. Our patients are typically safe and they have a protective effect if their steroids are less than 0.5 milligram per kilogram, and if they are on Imurin, for instance, only. So the majority of patients with autoimmune hepatitis are likely to have a sustained response. But we certainly don't know what that novel vaccine is going to look like. Yep.
Great, thank you. We'll go back to you, Dr. Gabriel, now with another question. Our members are wondering, as quarantines are lifted and life begins to return to normal, hopefully sooner rather than later, how can people with AIH or anyone that is immunosuppressed or post-transplant have a normal life, especially in a time when a vaccine does not yet exist and new coronavirus infections are on the decline?
Thank you. That's an excellent question, and certainly one that we would struggle with as well. My sense is that as we learn more, we may have better guidance for our patients who are immunosuppressed. I do think a lot's going to depend on the kind of work that they do. So as a healthcare worker, I think exposures would probably continue to be concerning. And I think under no circumstance that I can imagine so far would we okay immunosuppressed healthcare workers to be exposed to COVID-19 patients. But hopefully we'll understand more over time. I think we'll understand more as we go. Right now, the general sense and the general position of liver societies is that patients that are immunosuppressed are at increased risk, and we are recommending caution and avoiding any potential exposures and social distancing. But stay tuned.
Yeah, I think you're right, Dr. Gabriel, and I think not only with immunosuppressed, but even other people that are not immunosuppressed, it will be a new frontier as we leave our homes. And just kind of in follow with that, Dr. Gabriel, could you comment? This is highly debated often on our groups, and the idea about NSAIDs like ibuprofen or Motrin being asked to stay away from these in COVID-19. But we also know as hepatologists that these medications also carry other risks as well. Is there a way that you could counsel a patient in regards to the risk of NSAIDs along with Tylenol for COVID-19, but also just in general in relation to liver disease?
So perhaps the last part of the question is the easier one, Craig. So,
sure.
In general, we end up not using a lot of NSAIDs. In my transplant world, we don't use them post-transplant. We're always worried about kidney risk. And also in advanced liver disease, we also are concerned about GI bleeding and kidney injury as well. So NSAIDs tend to be something we always advise against. Specifically for COVID-19, I would look to something like the FDA for guidance, and really there's been not sufficient evidence for at least the FDA so far that I know of to make a statement to stop using NSAIDs specifically. I would say that the flip side of NSAIDs for fevers would be Tylenol, and we've always favored using Tylenol, certainly in limited doses in patients that do have advanced liver disease or transplant, but limited doses of Tylenol are considered safe in our world. And that would be the go-to agent for symptomatic analgesia and something for fevers.
Thank you. Dr. Irma, we'll go back to you with a final question about pets. I'm concerned about pets as a possible risk for transmission. Is there an issue having a dog that goes outdoors and then sleeps on the covers with us in bed? What about our shoes we wear? Do we need to stay out of the house? Those need to stay out of the house?
Yeah, so this was a question that actually came up pretty early on in the pandemic partly because the physiology of these viruses is that they have other animal intermediary hosts, namely bats. Pangolins have actually become quite famous for this. However, dogs have actually been found they aren't really able to harbor the virus. So from that aspect, you can't give it to your dog can't carry it and give it to you. The concern, I think, that maybe somebody would, that a dog would have infectious droplets on fur is actually pretty low. I don't think anyone's really looked at it. So as far as any experimental data, we don't really have it. But if your dog just goes outdoors, they're going to be fine simply because the virus itself is not being spread on the wind like that. It's really a very short, distant droplet spread. And the same thing can be said about shoes. Unless you're in a heavily exposed environment, so we do have kind of this trend in healthcare workers who come home, actually remove all clothing that they had worn in the hospital, like at the entrance of a house, including their footwear, and then throw everything immediately in like the laundry and then go take a shower. We actually don't have evidence that that needs to be done or that would really help the situation. So I think you're fine, or anyone would be fine to wear their shoes in their house with that regard, because it's not going to be out so much in kind of the ambient world that you're not going to find it as much unless you're heavily exposed like a healthcare worker.
Great. Thank you. And Dr. Ermel, Dr. Mietke, Dr. Gabriel, on behalf of the AIHA, as well as the Center for Autoimmune Liver Disease, we want to thank you all for your amazing contributions tonight. We're going to sign off now, but I want to make sure that our patients and families and caregivers all know that we'll have these conferences every 2 weeks, same time, same place. We may use this platform, we may evolve or change. Again, remember, this data is coming quickly. So we do want to be there for you. We want to be a clearinghouse, a way of giving you the information. Future topics could be beyond this virus and actually coping strategies or treatment approaches that are evolving. So stay tuned. Again, thank you for speakers. Thank you, Aaron Anderson, for co-moderating. And we'll see you guys again in a couple weeks. Thanks again.